Imagine going to 3 different mechanics because your car's engine is making this terrifying rattling noise.
Okay.
The first mechanic, he just tightens a belt. The second one tells you to buy a completely new engine.
Wow, quite the jump.
Right. And then the third one looks you dead in the eye and suggests the rattling is just caused by your stress levels.
Yeah, you would probably grab your keys and drive away as fast as you could.
Exactly. You'd think they were all completely out of their minds.
Totally.
But if you suffer from chronic pain or, really any complex long-term health issue, that is exactly the kind of maddening, conflicting advice you get every single day.
It's just a constant cycle.
It is. The standard model of, hire an expert, find the broken thing, and fix it. It just completely falls apart.
Right, because the human body isn't a car.
Exactly. So you end up bouncing from a rheumatologist to a neurologist to an orthopedic surgeon. One specialist gives you a pill, another suggests major surgery, a third tells you to, take up yoga.
And you're just left standing there.
Yeah, holding this massive folder of printouts, paying all these copays, and feeling completely lost in a medical system that seems to be speaking 5 different languages at once.
It is an incredibly disorienting experience. The traditional healthcare system is brilliantly designed for acute crises.
Like an emergency room type thing.
Right. If you shatter your leg in a car crash, the system knows exactly what to do. They fix the bone.
Sure.
But when dealing with overlapping chronic conditions, it frequently stumbles. It just leaves the patient to somehow figure out how all these disparate pieces fit together.
Which is exhausting.
Yeah.
And that brings us to the mission of today's deep dive. We are figuring out how you can pivot from being a passive recipient of medical care.
Right, just sitting on the exam table.
Yeah, just waiting for a white knight to save you. We want to move you from that to becoming the active project manager of your own multidisciplinary medical team.
And to build this roadmap, we are pulling from a really diverse stack of medical literature today.
Some heavy hitters.
Oh, absolutely. We are looking at official clinical guidelines for major spine surgeries and opioid prescribing. We've got holistic patient handbooks from places like the University of Wisconsin.
Nice.
And this massive psychiatric umbrella review covering nearly 18 million people.
18 million.
Yeah, it digs deep into the biological connections between chronic pain and mental health.
Okay, let's unpack this. Because to start, we really have to recognize a hard truth here. The traditional medical model of go to doctor, get a pill, be cured is fundamentally broken for long-term conditions.
It just doesn't work.
Right. Before we can even begin to build your medical cabinet, we have to understand what that team is actually trying to achieve.
Because if you assemble a team with the wrong goal in mind, you are setting yourself up for failure from day one.
Exactly.
The shift that needs to happen, and you see this explicitly detailed across all the clinical guidelines we reviewed, is moving away from the often impossible goal of zero pain.
Or a total cure.
Right, moving away from that and pivoting toward a sustainable goal of functional quality of life.
Which honestly sounds a bit like settling.
How so?
Well, if I'm the patient and my back is screaming, I don't want functional quality of life. I want the pain gone. I want to feel like I did 10 years ago.
Oh, of course. It is a completely natural human reaction to want the pain completely erased. But the American Academy of Pain Medicine emphasizes that pain isn't a simple binary.
Okay.
There are no neat, arbitrary buckets of acute versus chronic pain. It is a continuum.
So it blends together.
Exactly. It starts acutely, say with an injury, but whether it progresses to a chronic state is influenced by this massive web of genetics, your environment, and the psychological and social factors surrounding your life at that time.
So if getting back to a perfect 0 on the pain scale isn't the metric for success, what actually is?
Well, in the clinical guidelines, achieving a 30% improvement in pain is actually considered a major clinically meaningful milestone.
Only 30%?
Yes. But, and this is the key caveat, only if it improves function. The focus shifts entirely to your physical, emotional, and social role.
So it's about what you can do.
Exactly. Whether that's returning to a desk job or just being able to sit on the floor with your kids, rather than just the raw number you circle on a pain scale.
Let me go back to my mechanic analogy for a second.
Hate to lay it on me.
The traditional symptom-chasing medical approach feels like a mechanic trying to turn off a flashing check engine light by just, taking a hammer and smashing the bulb on the dashboard.
Right, out of sight, out of mind.
Sure, you don't see the light anymore, but the engine is still struggling.
Yeah.
But if we shift to just focusing on function and accepting a 30% reduction, are we just telling patients to accept their suffering? Are doctors essentially giving up on finding the root cause?
What's fascinating here is the psychological concept of acceptance of pain, which it sounds incredibly passive, but is actually a highly active strategy.
It sounds like giving up.
It's vastly different from giving up, I promise. The research shows that when patients view their pain as completely unacceptable, they attempt to avoid it at all costs.
Makes sense.
They doctor shop. They seek out more and more invasive interventions to eliminate it. But these efforts frequently result in zero reduction in pain.
Wow.
And the pursuit itself causes patients to miss out on actually living their lives.
So they spend all their waking energy fighting a war they mathematically cannot win.
Exactly. And in doing so, they become more isolated and depressed. Multiple studies demonstrate that when patients reduce that avoidance, when they accept the pain as a current reality and redirect that immense energy toward goals they can actually achieve,
What happens?
they paradoxically report lower pain intensity, less pain-related anxiety, and a massive drop in depression.
Wait, hold on. By simply accepting that the pain is present, the physical sensation of the pain actually decreases.
Yes.
How does that work mechanically, like in the brain?
It all comes down to neuroplasticity, the brain's ability to physically rewire itself. Chronic pain often means the brain's alarm system is stuck in the on position.
Hypersensitizing your nervous system.
Right. But when patients prioritize active interventions, things like a gentle, graded increase in movement, disciplined sleep routines, and counseling, they are sending new, safe signals to the brain.
Oh, I see.
Over time, those active behaviors actually help rewire the brain's pain maps. So we aren't abandoning treatment at all. We are shifting the focus from a desperate war against the feeling of pain to a highly strategic campaign for better living.
Okay, so since a single magical cure isn't the goal, looking for a single magical specialist is a total waste of time. You can't just walk into a spine surgeon's office and expect them to handle your sleep hygiene, your physical therapy regimen, and the emotional toll of being sick.
No, you really can't. You need a diverse cabinet of advisors. And based on the massive data sets we're looking at, that cabinet absolutely must feature mental health professionals.
Not just as an afterthought.
No, as a core pillar.
Here's where it gets really interesting. We looked at that umbrella review, published in European Psychiatry, the one that synthesized data across nearly 18 million people.
A staggering sample size.
It is. So we already know that roughly 25% of the global population deals with some form of chronic pain. But when you filter that data to look specifically at psychiatric populations, those numbers just explode.
The prevalence rates are almost hard to believe. In patients diagnosed with post-traumatic stress disorder, the prevalence of chronic pain reaches up to 96%.
96%.
Yes.
That essentially means having severe emotional trauma like PTSD almost guarantees your physical body will develop a chronic pain condition.
It does. And the pattern holds across the board. The prevalence is almost 54% in older adults dealing with major depressive disorder and nearly 24% in individuals with bipolar disorder.
That is wild.
There is a deeply entrenched bidirectional link here. Having physical pain in multiple areas of your body almost doubles your risk of developing major depressive disorder.
And conversely, already having depression dramatically increases your risk of developing chronic physical pain.
Exactly.
They feed off each other in this terrible loop. But why? Like, biologically, how does being depressed literally make your knee or your back hurt more?
If we connect this to the bigger picture, it becomes clear that the brain does not use separate hardware for physical and emotional suffering.
It's all the same wiring.
Exactly. They share the same underlying mechanisms and neurochemistry. When you are dealing with prolonged stress or severe depression, your brain depletes essential neurotransmitters like serotonin and dopamine.
The feel-good chemicals.
Right. And those are the exact same chemicals the brain uses to close its pain gates and dampen physical pain signals from the body.
Oh, wow.
So when depression lowers those chemicals, the gates just fly open. The nervous system becomes sensitized and normal physical sensations are amplified into severe pain.
So the alarm system is screaming, and the brain has basically run out of the chemical tools it usually uses to turn the volume down.
That's a great way to put it.
And this vicious cycle, I mean, it isn't just a physical and emotional toll. It creates a massive financial crater. The data shows that when someone has comorbid pain and depression or anxiety, meaning they are suffering from both at the same time, it costs an additional $5,208 per patient annually.
Compared to other diseases, yeah.
And that is mostly driven by desperate emergency room visits and lost productivity.
Which brings us to this solution. How do you treat a systemic alarm malfunction? You utilize pain management programs or PMPs.
What do those look like?
These are comprehensive, multidisciplinary programs. They move away from throwing more medication at the problem and instead involve group treatments, cognitive behavioral therapy, occupational therapy, and physical conditioning.
Right.
And to make this work, your general practitioner, or GP, needs to step into the role of the quarterback.
I love that framing. The GP is the quarterback calling the plays, looking at the whole field, rather than just focusing on one knee or one vertebra.
They coordinate the overall strategy. In places like Australia, for example, a GP can draw up a formalized Medicare-funded care plan.
Oh, that's incredibly useful.
It is. This allows the patient to access subsidized rebates for allied health professionals, essentially putting a physiotherapist and a psychologist on the payroll of your personal health team.
And I really want to hammer this point home. Bringing a psychologist onto your medical team isn't just about having a friendly ear to vent to because you were sad about being sick.
Not at all.
It produces measurable clinical outcomes for the physical pain itself. The review highlighted a trial on mindfulness-based interventions. And what completely blew my mind was that the mindfulness training did not lower the actual severity of the pain.
Right.
The physical burning or aching sensation remained exactly as intense. But it massively decreased pain interference.
Meaning it reduced how much that pain stopped them from living. Mindfulness essentially trains the brain to decouple the physical sensation from the emotional panic.
So you still feel it.
You still feel the ache in your back, but you are training the brain's alarm system not to sound the air raid sirens. You observe the pain rather than fighting it, which gives you the cognitive space to actually go about your day.
The psychological intervention essentially handed these patients their lives back, even while the physical sensation persisted.
Exactly.
Okay, so we know we need this diverse cabinet, a GP quarterback, a clinical psychologist, a physiotherapist. But as the strategist here, looking at the SOPs, here is the massive roadblock. How do you actually get the medical system to approve these treatments?
$1 million question.
And more importantly, how do you get your insurance to pay for them? Because as anyone who has been sick knows, you can't just walk in and demand a care plan. This brings us to the playbook. You have to understand the clinical standard operating procedures, the SOPs, that doctors are legally and financially bound by.
This is the friction point where patients feel the most profound frustration. They know their body is failing, they know they are in agony, but they hit these impenetrable bureaucratic walls.
It's infuriating.
To navigate this, as an implementer, the patient has to deeply understand the concept of medical necessity.
Right. It's like you have to become a trial lawyer for your own body. You can't just walk into a clinic, point to your lower back and say, "It hurts, I need surgery."
No, they won't even entertain that.
The clinical guidelines explicitly state that a patient's verbal history, your actual lived experience, is necessary, but it is considered a completely incomplete part of the evaluation process.
Establishing medical necessity requires a rigorous paper trail. The system demands past medical records, specific laboratory studies, objective imaging.
For example, I looked at the Washington State Guidelines for lumbar spine surgery. The criteria for getting a lumbar decompression or a spinal fusion approved are hyper-specific.
Oh, they are incredibly rigid.
You cannot get that surgery without checking a cascading series of boxes. You must have subjective proof, which means you have to use the exact right phrasing.
Like what?
Like complaining of radiating leg pain that is specifically exacerbated while standing and relieved by sitting. Then you need objective proof, which means a doctor has to document progressive motor weakness in your limbs. Then you need an MRI or CT scan that perfectly matches those physical symptoms.
And beyond all that, you need absolute biological proof of nicotine cessation.
Wait, hold on. This is where I have to throw a flag. If my spine is degrading and I'm in absolute agony, you're telling me I can't get the surgery I need to walk because I vape.
That's what the guidelines say.
That feels incredibly punitive. The guidelines demand tests to see if your body is metabolizing nicotine, specifically 2 negative urine tests conducted at least 1 month apart, before they will even consider approving the fusion surgery.
It's a high bar.
Is that really about health, or is that just the insurance company throwing up red tape to get out of paying for an expensive procedure?
Look, it is incredibly easy to view it as a hostile bureaucratic stall tactic when you are the one suffering. I completely get that. However, looking at the clinical rationale provides a different perspective. These guidelines are fundamentally designed to prevent severe medical harm.
How does nicotine cause harm in a back surgery?
Well, a failed back surgery can leave a patient in significantly more pain than they started with, effectively ruining their life. And nicotine severely constricts blood vessels, which drastically impedes bone healing and spinal fusion.
Oh, so the bone literally won't heal.
Right. The system is demanding these strict criteria to ensure that major irreversible interventions only happen when there is a high probability of success.
It is a brutal calculus of risk versus reward.
It is. And the same logic drives the opioid prescribing guidelines. Doctors are legally mandated to check state prescription databases, like the Curies database in California, to monitor every single controlled substance a patient fills.
So they know everything you're taking.
Everything. They must conduct random urine drug screens to verify the patient is actually taking the medication and not, using undisclosed substances. Patients are required to sign strict pain management agreements detailing the rules for refills and safe storage.
And the leash is incredibly short for post-operative pain, too. The guidelines we reviewed recommend a strict 3-day limit on opioids for rapid recovery joint surgeries.
Like repairing a torn knee cartilage.
Yeah. 3 days, and then you're cut off, regardless of how much it still hurts.
Those guardrails are a direct response to the opioid epidemic designed to prevent dependency. But for the patient, understanding these SOPs isn't just about knowing why you are being restricted.
It's a tactical advantage.
Exactly. When you know the exact rules your doctor is forced to play by, you can anticipate what they need to write in your chart to get your care approved. You can gather your records, track your specific symptoms in advance, and present your evidentiary case in the exact format the insurance system requires.
So if the system requires all this bulletproof documentation just to get a basic treatment approved, how does a patient who is already exhausted actually gather all that? Like, from an implementation standpoint, how do you take the reins and step into the role of project manager?
It begins with stepping back and assessing your whole life, not just staring at a 1 to 10 pain scale. One of the most effective tools highlighted in the University of Wisconsin Integrative Health Materials is the Personal Health Inventory, or PHI.
Oh, they shared a fantastic case study in those materials about a patient named Matt that really illustrates this. Matt was a guy relying entirely on high-dose medication to manage his chronic pain, and he was miserable.
Just surviving day to day.
When he filled out his personal health inventory, he rated his mental and emotional well-being at a dismal 2 or 3 out of 5. But the most crucial part of that inventory was identifying his why.
Right. Why did he actually want to get healthy?
And Matt's answer wasn't a clinical metric. It wasn't, I want to reduce my lumbar inflammation by 20%. His answer was his family. He wanted the stamina to play with his young children, to spend quality time with his wife, and to get back out into the woods to go hunting and fishing.
And once Matt defined that why, everything shifted. He stopped being a passive patient waiting for a miracle pill and became the CEO of his own health.
He took charge.
He actually decided to focus on his mind and emotions first, that mental health pillar we talked about, learning breathing exercises and imagery. And he implemented SMART goals to get there.
Using SMART goals is such a game changer for patients. The acronym stands for specific, measurable, agreed upon, realistic, and time-based.
It gets you out of the vague complaints.
Exactly. Instead of telling your doctor a vague goal like, I want my back to hurt less, a SMART goal looks like, I want to be able to walk the dog for 15 minutes every Monday, Wednesday, and Friday morning by the end of next month.
It gives your medical cabinet a tangible, functional metric for success. And stepping into that project manager role means adopting the tools of a manager.
Like using Notion.
Yes, we're talking about using digital systems like Notion or specialized health tracking apps to organize your medical records, log your daily symptoms, and track your SMART goals.
So you aren't relying on memory when you finally get your precious 15 minutes with a specialist.
Exactly. It also means becoming your own lead advocate. The patient handbooks explicitly advise patients to be the squeaky wheel.
Don't just take no for an answer.
Right. If your insurance denies a referral to a psychologist or a physical therapist, do not just accept the automated no. File an appeal. Utilize your state's health advocacy offices. Prep for your medical appointments the same way an executive prepares for a high-stakes board meeting.
You walk in with a printed timeline of your symptoms. You document exactly what activities spike the pain and what provides relief, effectively doing the doctor's charting for them.
Which they usually appreciate, by the way.
And if the standard clinic isn't cutting it, you actively research immersive inpatient pain management programs, or you dig into clinical trial databases to find cutting-edge therapies that aren't even on your GP's radar yet.
You really have to hustle.
So what does this all mean? It means the era of sitting passively on the exam table is over. You have to be the CEO. You hire and delegate tasks to your medical cabinet. your GP quarterback, your physical therapist, your psychologist, but you retain absolute executive control over the direction of your care,
This raises an important question, though, regarding the power dynamic in that exam room.
which can be tricky.
Very. The literature acknowledges a very harsh reality. Patients with complex chronic pain are frequently met with intense skepticism by the medical system.
Because it's invisible.
Right, because nervous system sensitization often cannot be seen on an MRI or a simple blood test. Patients face doubt and sometimes outright accusations of malingering.
Of making it all up.
Yeah.
Which is absolutely devastating. You are already suffering, and the person who is supposed to help you essentially calls you a liar.
It causes profound medical trauma. Therefore, patients must actively demand a model of shared decision-making.
What does that look like in practice?
The clinical guidelines emphasize that a good provider is, first and foremost, one who simply believes you. A provider who validates your report of pain, even if they cannot immediately pinpoint the physical source on a scan.
And if they don't?
If a specialist does not offer that fundamental, basic validation, they should not be in your cabinet.
You fire them, and you find a new contractor who respects the project manager.
Exactly. You are the one who has to live with the results, so you have to be the one calling the final shots.
To pull all of this together, escaping the labyrinth of chronic illness requires a total rejection of the passive patient mindset. It requires understanding the deep, biological, bidirectional link between your brain and your body.
Knowing that treating your mental health is literally treating your physical pain.
Right. It means decoding the system's strict clinical criteria so you can build an airtight case for your own care, and ultimately taking on the relentless, highly organized role of the medical project manager.
It is a massive shift in responsibility from the system to the individual.
It really is.
And it leaves us with a final, rather provocative thought to consider.
Let's hear it.
We've established that surviving complex illness requires you to act as a highly functional, relentless CEO. You have to track data, manage a team of specialists, and battle insurance bureaucracies.
Sounds like a full-time job.
But if the very nature of chronic pain and severe depression inherently drains your physical energy, destroys your cognitive focus, and impairs your executive function,
Yeah.
how do we redesign a medical system for the millions of people who are simply too sick to be their own project managers?